Okay, let's dive right into this explainer. We're going to trace the anatomy of the ear to uncover 20 absolutely critical ATI and NCLEX key points you need to know. Look, if you're prepping for your nursing boards, you already know sensory disorders can be pretty tricky. But by mapping out the anatomy and pairing it with clinical judgment, we're going to lock this info in for good. We'll systematically break down the external, middle, and inner ear, pulling the absolute highest yield concepts straight from the source material.
Here's our roadmap for today. We're covering 1. External ear essentials. 2. The middle ear and mastoid. 3. Inner ear and balance. 4. Managing Meniere's disease. 5. Ototoxicity and presbycusis. And finally 6. A final NCLEX review. Let's get to it.
Section 1, External Ear Essentials. We're kicking things off at the external ear. Now, this is where simple issues like impacted cerumen, earwax, or localized inflammation often trip students up on exams. It might seem super basic, but the nursing interventions here are incredibly specific and honestly tested all the time.
When you're dealing with severe erythema and swelling of the auricle, you're usually looking at external otitis, commonly known as swimmer's ear. And that brings us to our very first NCLEX key point. The hallmark sign of external otitis is pain that aggressively increases when the auricle is pulled. Seriously, if you've got a patient who winces just from you touching the outside of their ear, you are likely dealing with an external canal issue, not a middle ear infection.
So when we treat these external issues, we've got to be extremely careful. High yield alert for points 2, 3, and 4 on our checklist. Point 2, never ever irrigate if the tympanic membrane is ruptured. Why? Well, if the eardrum is perforated, flushing fluid can literally force bacteria directly into the inner ear, sparking a massive infection. Point 3, always make sure ear drops are at room temperature. Cold drops can trigger severe dizziness and vertigo, and nobody wants that. And point 4, if you're using heat to reduce pain, apply it to the affected ear for exactly 20 minutes a day, no more, using a heated towel or pad.
Section 2, Middle Ear and Mastoid. Moving a bit deeper into the anatomy, fluid buildup and pressure here become huge clinical priorities. Remember, the middle ear connects to the throat via the eustachian tube, which makes it highly vulnerable to respiratory infections that kind of just migrate upwards.
This dynamic perfectly illustrates our 5th and 6th points. For chronic otitis media, myringotomy tubes, sometimes called grommets, are intentionally placed to allow continuous drainage of fluids and equalize that pressure. But if it's left untreated, the pressure just builds and builds, and the eardrum can actually spontaneously rupture. That causes a painful perforation, which eventually leads to scarring and subsequent hearing loss. Definitely a bad outcome.
So the crucial takeaway here, and point number 7 for your NCLEX, is recognizing that chronic otitis media isn't just your run-of-the-mill earache, because the middle ear is directly connected to the mastoid bone and sits dangerously close to the brain. Chronic infections carry severe intracranial complication risks. We're talking life-threatening conditions: meningitis, brain abscesses, mastoiditis. Always monitor these patients for stiff necks or swelling right behind the ear.
Now remember this number for point 8. When a patient undergoes a stapedectomy, which is a surgery to treat a conductive hearing loss condition called otosclerosis, the surgeon places packing inside the ear canal. Your absolute top priority as a nurse is to ensure that packing remains completely undisturbed for approximately 1 week. Seriously, don't touch it, don't change it, just let it be so the surgical graft can actually heal.
Section 3, Inner Ear and Balance. Okay, let's travel even deeper to the inner ear and see how this all connects to complex balance disorders that show up constantly on nursing boards. The inner ear isn't just about hearing, right? It's literally the control center for our equilibrium. Point number 9 is all about mastering the clinical definition of vertigo. Vertigo isn't just feeling a little lightheaded or swooning. It is a severe, debilitating sensation where patients feel as though they or the entire room around them are violently spinning. It's often paired with intense nausea and vomiting, and, here's the kicker, it creates a massive risk for falls. Any patient with true vertigo is an automatic, non-negotiable high fall risk on your unit.
Section 4, Managing Meniere's disease. This leads us directly into Meniere's disease, which is an inner ear disorder characterized by an accumulation of fluid in the labyrinth, a condition known as endolymphatic hydrops. I would argue this is the most tested ear pathology of all on nursing exams, mainly because the symptoms are so severe and the management requires really specific patient education.
Hitting NCLEX points 10 through 13, we need to know exactly how to manage an acute Meniere's attack. Point 10, prioritize safety.
Keep the patient absolutely still in a dark, quiet room. Any sudden movement or bright light, that can trigger profound vomiting. Point 11. When they're not in an acute attack, they need to be drinking plenty of fluids. Point 12. Absolutely restrict sodium in their diet to prevent that fluid from building up in the inner ear again. And point 13. Strictly avoid alcohol, caffeine, and tobacco. Those are known triggers that will just make their symptoms so much worse.
Section 5. Ototoxicity and presbycusis. Next up, we really need to examine how external factors, and just the natural aging process, impact these incredibly delicate anatomical structures. We're focusing on ototoxicity, which is chemical damage to the 8th cranial nerve, and presbycusis, which is age-related hearing loss.
High-yield points 14 through 17 revolve around recognizing 4 specific major drug classes. Point 14, aminoglycoside antibiotics like gentamicin. Point 15, loop diuretics, think furosemide. Point 16, salicylates, which is aspirin. And point 17, anti-neoplastic chemotherapy agents like cisplatin. Every single one of these can destroy hearing. You have got to monitor patients on these meds super closely, especially if they have poor renal function. Think about it. If their kidneys aren't working, they excrete the drugs way slower, which dramatically spikes the risk of ototoxicity.
So, the crucial, absolute must-know point for number 18 is this. Ringing in the ears, tinnitus, is your ultimate red flag for ototoxicity. It's usually the very first sign that the 8th cranial nerve is taking damage. If your patient on gentamicin or high-dose aspirin suddenly says, "Hey, I hear a buzzing or ringing sound," you must hold that medication and contact the healthcare provider immediately. You have to intervene before that temporary ringing turns into permanent, irreversible hearing loss.
Section 6. Final NCLEX Review. Okay, let's put all this knowledge to the test. We're going to run through some rapid-fire clinical judgment questions, pulled directly from the source text. This is where we really solidify these concepts.
4.19. Imagine you're about to administer an immunoglycoside. Based on everything we just discussed about inner ear damage, what specific instructions are you going to give your patient right then and there? Exactly. You want them to report any ringing. Because, like we said, tinnitus is the hallmark, early warning sign of ototoxicity. Catching it early can literally mean the difference between a temporary, annoying side effect and permanent, lifelong deafness for your patient.
Now think back to our inner ear journey for this final 20th key point about managing severe vertigo. Let's say a patient comes into the ER. The room is spinning, they're intensely nauseous. What is your immediate number 1 priority?
You must minimize all environmental stimuli. Keeping that room dark and quiet prevents the vertigo from spiking, which in turn prevents severe vomiting and a potential fluid volume deficit. Safety and sensory reduction are your absolute top nursing priorities in that moment.
Let's do a bonus active recall question regarding that external ear procedure we went over at the very beginning of this explainer. You've got a patient with severe external otitis, and there is a narrow piece of gauze sticking right out of their ear canal. What's your move?
The correct action is to apply the prescribed drops directly onto that piece of gauze. Whatever you do, never pull the gauze out. That narrow strip is an ear wick. The healthcare provider intentionally placed it there to literally draw the medication deep into the canal, pulling it right past all that severe swelling and edema that would otherwise completely block the drops.
Let's end with one final test of your anatomical and surgical pathology mapping. We talked about a very specific surgery earlier, where the ear packing has to stay totally undisturbed for a week. What disease process requires a stapedectomy? It corrects otosclerosis, which is a condition where the stapes bone in the middle ear becomes fixed and just can't vibrate anymore. Well, with these 20 key points mastered, you are more than ready to absolutely crush ear and hearing disorders on the NCLEX. But as we wrap up this explainer, seeing just how deeply the ear connects to balance in the brain, it definitely leaves you wondering how these localized sensory issues might overlap with much more complex neurological disorders, doesn't it? Keep studying, keep making those big picture connections, and I'll catch you in the next one.